This is, going to have all kinds of uproar and stuff for exactly the reason that we've been talking about for a couple of years, which is people think that they can see from the outside what's going on the inside. And sometimes that's true. You can. But the reason that we are so bad at the 2-3 boundary, right? We're about 43% accurate on deciding who's sick and who's not sick. So all these people who are like, "Oh, I know sick from not sick." They're wrong. They're just wrong. And so your well appearing ill and your ill appearing well get, correctly bucketed with a set of vital signs. So that's why you have to do it.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement because we all know emergency nurses have the best stories. Now, here's your host, Kevin McFarland.
Intro music threw you off, and chances are you're listening to this on the How Not to Kill Your Patient podcast. Let me tell you what we did. For this topic, we think it's such an important topic, we decided to launch this particular episode on both the Art of Emergency Nursing podcast and the How Not to Kill Your Patient podcast simultaneously. So if you've already downloaded the podcast on one platform, you don't necessarily need to download it again. Not that I'm complaining, because the additional download numbers are always great. Now I want to put out our typical disclosures. The podcast episode that you're about to listen to are the opinions of me and Lisa only. They do not necessarily represent our organizations that we work for, volunteer with, or are associated with in any way. The opinions are our own. But like we say in the How Not to Kill Your Patient podcast, what more do you need? So sit back, grab your favorite caffeinated beverage, and enjoy this episode. So, all right. So we are going to talk today about the updates to the ESI Triage algorithm, which has been updated. We are now on version 5 of ESI. And this is the first one where it is truly a ENA product, which makes it a little different than it has been previously. ENA bought the rights to that and then kept on
Yeah.
the legacy of tweaking that and making sure that it was relevant and up to date and all that kind of stuff. And today we're going to talk to Lisa Wolf, who is the first contributors for the update to the ESI Triage algorithm. So let's talk a little bit about this. Are there big changes that people need to be aware of for ESI? It
Yeah.
seems.
Yeah, actually, I think we're kind of codifying the thing that we've been talking about, you and I have been talking about for like a couple of years now, which is vital signs. Vital signs on every single patient. You cannot assign, unless your patient's, coding, right? You cannot assign an ESI acuity level without vital signs. This is, going to have all kinds of uproar and stuff for exactly the reason that we've been talking about for a couple of years, which is people think that they can see from the outside what's going on the inside. And sometimes that's true. You can. But the reason that we are so bad at the 2-3 boundary, right? We're about 43% accurate on deciding who's sick and who's not sick. So all these people who are like, "Oh, I know sick from not sick." They're wrong. They're just wrong. And so your well appearing ill and your ill appearing well get, correctly bucketed with a set of vital signs. So that's why you have to do it.
Now I remember, and I know I've told this story on the podcast probably more than once, but I remember going to a new ER as the ER director, and I remember the expert in triage was telling me how, I was watching her do triage and she wasn't checking vital signs. She was just getting a history and then scooting people out into the waiting room and saying, "Okay, we'll see you when we see you." And I asked her, I was like, "What are you doing?" And and she very much told me that she was the ESI expert. And I was like, "Okay." And I'm like, "But you're doing it wrong. You're not getting vital
Right.
signs." And she's like, "Well, vital signs are not really required in the book." And I'm like, "But they're really required to get that 2-3 border, right? And that 3-4 board, like to differentiate those." And I'm like, "You can't do that without a good set of vital signs." Like,
Right. And
what do you think?
I think people have initially it said consider vital signs.
Yeah.
right? In your and I think people misinterpreted that to mean like consider taking them rather than consider them in your decision making.
Yeah. Yeah. It's just crazy to think that anyone would think that you can do a triage without getting vital.
Right, right. I mean, you wouldn't delay treatment for somebody who couldn't breathe, was unresponsive, was, coding, right? Like an ESI 1 that you would never stop, right? Like, "Do not pass go, please come right
Yeah.
in."
Yeah.
For the most part, but anybody who's not in extremis, you have to take a set of vital signs on because that, person with the arm lack may have a heart rate of 130, and that means something else is going on, right? So, like, did the injury happen because the patient had no cardiac output, right? Or, there those 2 things can be related in ways that aren't initially apparent. So given that, the algorithm now reads, level 1 is, requires life-saving intervention. That's pretty much the same. Although life-saving intervention is really much broader. I mean, and you and I have talked about this, when we talked about the importance of vital signs, right? Things that require life-saving intervention don't necessarily mean you're an extremist. It just means that it's extremely time sensitive, right? So, uh, glucose, glucagon, Narcan, adenosine, all of these types of things. Rescue BiPAP is a one, right? So you don't need necessarily to be administering CPR or actively in the process of intubating somebody for them to be an ESI 1. But what it does require is that you have an understanding of the pathophysiological process that's happening such that you can understand if I do nothing in 5 minutes or 10 minutes or 30 minutes, this patient is going to crump, right? And the thing to remember also is that you don't know how long they've been like this before they show up in your ER, right?
Abs-
So that 30 minutes is like could be expiring, as you hit, ESI 3
Yeah.
on your thing.
Now, so that looks to me that one category seems very much broader than the previous version. So,
Correct.
and if you look at the tables talk about the examples of life saving interventions, and it includes the airway breathing stuff, of course,
Mhm,
the electrical therapy, defibrillation, emergent cardioversion, external pacing, needle decompression, pericardiocentesis, ecotomy. Those are all the things that like that. Not surprising to anyone. Um, Blood administration, control of external hemorrhage. Of course, that's basics. Um,
mhm.
but then it's got a handful of meds here, which I don't remember that being in there previously. So it's got medications that are for the extremes: adenosine, atropine, dextrose, dopamine, epinephrine, and Narcan.
Yep.
So your typical narcotic overdose where they're
That's
not
fine.
breathing and you need to give Narcan, that would therefore be an ESI 1.
Sure. Because your
So you
patient's
get it
gonna die if
fixed
you don't give it.
because they're going to die if you don't give it.
Yeah.
Now, I got to tell you, I wouldn't think to put that as an ESI 1 because I'd be like, oh, it's an easy fix. But it
Medical.
does require immediate intervention.
Right. And also, an ESI 1 is not dependent on arrival method, right? And that's very specifically in there, is that the ESI 1 patient is not always brought to the emergency department by ambulance, but maybe dropped at the front door. Infants and children, because they are portable, are often carried in. So you cannot consider mode of arrival as a barrier to assigning an ESI 1.
And do you think people consider that a barrier before? You think people were like, they arrived by private car, then clearly
I
not a
think
one.
this shows up very much. Yes, I think if people come in through the front door rather than but through the ambulance bay, people figure, well, they can't be that sick
Hmm.
because they came in, right?
I,
Like of their
I
own volition.
Yeah, and I guess I've seen the extremes to make me think not to make that connection. Yeah,
Mhm.
because I pulled gunshot victims out of out of
Out
cars
of
where you're
cars.
like where you're like, how did this happen?" But you're right, the portability of infants makes it much more likely. I I think I've taken more infants immediately from the car from the
Mhm.
front door to the recess room probably than adults.
Right. Well, traumas. Think about traumas, right? The problem of geography. If you're here in my community hospital, you can't possibly be a trauma because traumas go to trauma centers, right? But that's not always true.
Yeah.
So really, and the number of people who jumped off of roofs or out of trees and but they landed on their feet, right? That absolutely, is an issue. And so I think it's really important to kind of like wipe the slate clean when you approach a patient, right?
Absolutely. So, would you say for the level 1, would you say the biggest change is kind of a broadening in ESI level 1?
I think so, in a really explicit caveat that arrival mode is not factor into the decision.
And was it specifically before? Because I guess I don't think of it
No, it
as
wasn't,
being
but I think what we were trying to do in this revision was really make
spell it out.
explicit, kind of answer the questions that people would always say, right? Like, "Oh, I never, even the conversation that we had, like, I would never consider that an ESI one. Well, maybe we should make that really explicit then, what the conditions are to assign an ESI one. So the issue is like there's a problem of geography, right? Why are you in my community hospital if you're a trauma patient, right? So that's one. The second is disposition, right? So you're talking about, Noxalone administration or even D50, right? That's an easy fix. Those patients are going to go home. We're not going to admit them, but that doesn't mean that they're not ESI ones.
Yeah, I guess my thought process has always been like, there are 2, they're not necessarily a 1, but you're right. I mean, they need life-saving immediate
Right.
intervention.
Focus on the moment, right? Like not the trajectory. You don't want to, and I think there are some systems out there that really like the HOP score, right? Like really talks about what's the admission probability, right? But that doesn't focus on the patient coming in the door and what they look like right now and what they need right now, not what they're going to need in 6 hours,
What was that
right?
score that you just mentioned?
Well, the HOP score. I don't
HOP
know if you
score.
want
I've
to throw
never
this
heard of the
in.
HOP score. What's the HOP score?
Yeah, it's out of Hopkins, and it's sort of an alternative way of managing throughput. Um, I wouldn't call it a triage system because it really focuses on where they're gonna what their disposition is gonna be
Hmm,
based on their presentation. But in something like this, you that it doesn't align, right? If somebody
uh,
comes in with chest pain, and they're 65 years old, you're pretty sure they're gonna be admitted to telemetry, right? So you would, as a house supervisor, you go through the ED and look at the board and be like, oh, yeah, okay, telemetry, 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 maybe ICU, right? And you'd start thinking about your beds and your throughput,
every single day.
right?
Like,
I mean, I did that too for
that's
years and years,
that's, 7:30 PM,
right?
look at the
How
board.
many beds am I going to need? What do I need to staff? Like all that kind of stuff. But
Yeah.
that's on the back end. We still need to recognize the acute patient at the front door and take care of them immediately, right? It's not like, oh, don't worry, they'll be admitted, right? Because I think once people have a disposition, people like stop looking for decompensation. Like, oh yeah, we already have a decision on them. Like they're done, they're buttoned up, right? But they're not
Oh,
at the front door. And so
all the time.
to categorize people by disposition, potential disposition is I think really a challenge. So even think about like the intoxicated patient, right? Really like lethargic, snoring respirations, like, found under a bridge kind of person. That person's not going to probably not going to be admitted. We're going to help them to sober up. We might give them some, a banana bag and some food and get them hooked up with resources, but they're not going to be admitted to the hospital. But if you're unresponsive with an impaired airway, you're a one. Right? Like that's what you are. So the idea that what's going to happen down the road informs the triage decision is not good. That's not a good way of thinking about it because it cuts you off from really seeing the acuity in front of you,
Gotcha, gotcha. Okay. That's,
right? So I think the second thing that's really what I love about this, right? I'm just going to be like all excited about it. is that there are citations up the ass on this thing, right? Like, went through and cited just about found a supporting citation for just about everything we say in this right now, which I think lends it a little more weight, right? And a little more usability as a standard, right?
Was the citations a little light on the last edition?
A little light is putting it gently, yes.
Gotcha.
So, you know me, like, you didn't cite it, it didn't happen. So, especially with the ESI 2s, that becomes really important, right? What's high risk? How do we look at high risk? And this is where the idea that you must take a set of vital signs on everybody comes in, because people are like, well, if they're a 1 or a 2, I'll take vital signs. And well, how do you know if they're a 2 or a 3 if you don't take vital signs on them, right? So this is really where this becomes critically important, right? So what we see in terms of um like predictors of mortality, predictors of decompensation, blood pressure, heart rate, respiratory rate, O2 set, right? Like those are the things that tell us, is this patient in distress, right? Is their body stressed? Are
Yep.
they um, compensating? And when is that going to run it, right? So specifically, we know that respiratory rate, which nobody ever takes, please take your respiratory rate, and tachycardia are independent predictors of adverse events, right? Because that's your sepsis patient right there.
Yep. 100%.
So another thing that we talk about, right? So the high risk presentation, we also include in that, right? Are changes in mental status, which are always a 2, right? Or a 1. Changes in mental status, even if you know the reason, you think you know the reason, right? And also severe pain or distress. And when we talk about both stability and things like distress, we're talking about physical and psychological, right? So the patient who is in great physical distress, right? So pain, difficulty breathing, some kind of mobility issue, right? Sudden mobility issue, neurologic change, right? That person is always a 2, right? At least
Yeah.
a 2. But also that patient who is in psychological distress can also be a 2, right? So your suicidal patient, your hallucinating patient, your psychotic patient, all 2s.
All twos.
Also, though, people
But
who are responding to an event with great distress, so post assault, right? Those patients are 2s, right? Maybe perinatal loss, also 2s.
now, is that a change from previous? Because
I think it's just,
I
again,
think
more
suicidals have
explicit,
always been a 2, always a 2 no matter what.
right?
Um,
But it's
but
just more explicit,
okay.
right? And I think what we really wanted to do in this is change from like a list of diagnoses to a list of presentations, right? Like almost more almost more nursing diagnosis, right? Like what's the effect on the patient, because that's all we can see from where we sit in the triage booth, right?
So more based on presentation than diagnoses, did you say?
Nursing diagnoses, right? So ineffective airway, ineffective perfusion, impaired gas exchange, stuff like that, right? Rather than limiting, right? So this is, I think, really important when you use this approach, right? Which doesn't mean you have to have your little carpenito, but just like understand what you're looking at. It does, when you use terms like that or descriptions like that, you don't link yourself to a medical diagnosis right away, right? Which leaves you more open to really look at like what is happening here and what are the risks, right?
Absolutely.
Right. And I think another good thing in the handbook as it now stands is there are little like pediatric considerations, geriatric considerations, obstetric considerations, right? Stuff that kind of just like, remember this, if you haven't, you know, if you don't take care of pediatrics a lot, or if you don't take care of obstetric patients a lot, like here are some things that would just sort of spark you to think about their presentation is going to be a little bit different.
Yeah, I like the little highlights there. I think
I
that's
know, I like them too. They did a great job with layout. Like, I'm so proud of them. It's such a good job. Even noting like that a recent COVID-19 infection puts somebody at higher risk, right? It's because COVID is a disease of endothelium, which means that you are now at higher risk for stroke, for heart attack, for stroke, for MI, for PE, right? Any kind of clotting dyscrasia, right?
absolutely. Button batteries, got button batteries mentioned.
Yeah.
That's good. There's the ladies over at the Keyword podcast just did a episode on button battery ingestion.
Yes. Button batteries are like the great evil.
Yeah.
Yep. So I think we've tried to cover a lot of ground a little bit more specifically. And, I just think it's much clearer. I think there's a lot less room for people to be like, yeah, well, we don't really need to, worry about that.
Yeah.
So really where the actual big change is, as we go through like the level 2, the ESI 2 presentations, right? So we have ocular concerns, we have ENT concerns, we have, pulmonary and cardiovascular, obstetric now, which I know was in there a little bit, but I think the section's gotten a lot more developed. And I think that's really important because a lot of obstetric care is shifting to the emergency department. We're going to see a lot more pregnant people or, postpartum people. And that's just a content area that people are like, I have no idea. Like, I don't know what to do with that. Right.
Right.
It's going to be super important. Um, And then, and again, sort of like abdominal stuff, like here are your PD, Jerry, and OB implications, right? Trauma, transplant, behavioral health, ingestions, like all kinds of stuff. But then mm, the focus on the resources, right? I think is also really important because if you like, again, you can't assign somebody a 3, 4, or 5 until you've taken a set of vital signs. And I think prior to this, what we've said is if they don't appear to meet 1 or 2, you assign. Now you're going to think about resources, and then maybe you'll take a set of vital signs, right? But now the algorithm has shifted a little bit, so that the third decision point is, or the decision point D is reassess for a higher acuity level, based on vital signs. So that I think is a big explicit shift that was not there.
I'm just kind of scrolling down through the end of the section 2.
Mhm.
Look at all these references. Holy cow.
It's a lot of stuff out there. I mean, there's a lot of literature now on triage and how do you assess and how do you like what presentations mean what. I mean, there's a lot more stuff that you can use to support, what is a foundational document for emergency nursing,
Absolutely.
right? I mean, 94% of emergency departments in the United States use ESI.
That's a lot. I mean,
It's a lot. It's
that's
basically like this is what we do in the United States, as well as some other countries.
there's
Um,
very few ERs I've heard of do anything other than ESI. Now, and here's the funny thing. So I presented ESI triage, I don't know how many times, to in either nursing conferences or as a standalone course. And almost always I ask the nurses, I'm like, "Hey, what's ESI triage?" And they're like, I don't know. We just do triage." I'm like,
mhm,
"That it's ESI triage is what you're doing." So,
right.
um, unless you're, from another country. And now there's some places up north that use the more Canadian
Yeah, CTAS.
CTAS, which is probably great too. Um,
It's similar, but it focuses like their decision is about time,
Time, yeah, they're really focused on time more
right? Time
than
to
anything
provider.
else.
And so ESI does not do that.
Yeah, because we know in America, like that, just that time thing may not happen.
Right. Right. Well,
Uh,
I mean, the time is always challenging for me, right? So is it I feel like, people are like, "Well, time to provider." It's actually time to care, right? Because how many times back in the day did we have somebody, like, fixed, buttoned up, and getting better before the
before you,
provider walked in the
yeah,
room?
before you go and wake up the doc.
Right, exactly right, right? Get the guy out of the back. Yeah, so I think the idea that only a physician or, some other provider can provide care is kinda ridiculous in the ED setting.
Yeah,
So time to provider doesn't really it's not relevant in a lot of cases, right? Sometimes it is because, they have more different, better training in certain things, but like your basic, oh, this person is having an asthma attack. Let's get them an updraft. Let's get them some fluids and maybe, get the steroids ready to go. Right. And
yeah.
they're breathing much better by the time the doc walks in the room. If we had to wait for a physician to like write to determine care, like everybody would die.
Amen. Amen. So now we're at the next decision point, and that's where we're talking about resources. I'm looking at the old resource list compared to the new resource list. It looks like there's been some stuff added. Can't tell
Mhm.
if was there much added to the resources, or is it pretty much
I think there was a lot more like what is and what isn't a resource because I think what people had been doing and ultimately, like, does it matter whether you triage someone as 4 or 5? Probably not clinically. It doesn't matter clinically, but people were triaging based on what the provider wanted. Like what provide like, well, so and so is going to want this, this, and this. So the patient's a 3. When in fact the patient didn't need all those things, and the patient was actually a right?
yeah.
Or
And of course, because you have your providers, and every hospital has one. Insert Doctor So and So's name there that does the $1,000,000 workup for every single patient that walks through the
that's
door.
right. That's
And
right.
and we had, a couple of our fast track providers that would work up everybody for everything when you're like going, dude, they're here for a stub toe. Like, let's move on.
That's right. So, I mean, I think the idea about like what's the patient presentation, what are the interventions, what are the resources, right? Interventions and resources are not the same because some interventions are not resources, right? So, a kid who comes in with an ear infection, that's a 5. They're going to get oral meds, right? They're not a 3 because, Ralph the PA doesn't like to see kids, so the kid has to go to the main department. The kid's still a 5, even if they end up seeing somebody in the main department, right? So you can't, we talk about this a lot, like what determines acuity level? It's how many are in the waiting room and who's in the back, right? And we're trying to really get away from that in this revision, right? Like make it really clear. The other thing we're really trying to get away from is this idea of intuition, right? People like, "Oh, my gut says this person isn't so sick," right? And in fact, you're wrong almost all the time. Almost all the time. If you think a patient is less sick than they appear, you're wrong.
I'll never forget when I was a fairly new nurse. I remember triaging a person who kind of gave the kind of story. Her story sounded pretty good, like a stroke, and I was kind of like, "This lady is not having a stroke." Yeah, was what I said to myself as I put her in the room. I put her on the chart. I still made her a 3. I still made her she was, to where she was going to be seen pretty quickly. Um, but I was like, "This lady's not having a stroke. Like, this is bullshit. I don't know what it is, but it's bullshit." Um, the doc ordered the CT, and sure enough, she had a huge stroke. I was like,
That would make her a 2, however.
"Way to go, way to go, way to
Yep,
go, Dr. Kevin." Dr. Kevin kills the patient. Yeah, in hindsight, yeah, she probably should have been a 2. I think I made her a 3, but in hindsight, yeah, probably could have easily been a 2. And And with that said, we still got her seen pretty rapidly, but it was, like the whole time I was going like, this is all bullshit. And I was 100% wrong.
Mm. Yep.
So
Right. So I think this idea that, nursing judge or the nurse's best judgment, right? Mm-mm. Here's what it is. Here's why it's an algorithm. Here's how you stick to it. Right.
yeah,
And I think that's really the important thing. And then when we get to this piece around, the high risk vital signs part, right? Um, we make it really clear, like when vital signs are not obtained, the patient's at risk for being under triage, especially when they present with like vague symptoms, right? Of, let's see, this is there, we cite this great Iranian study of 551 cases who were up triage from a 3 to a 2. 88.7% had an increased respiratory rate, and 97.8% had an increased respiratory or heart rate.
wow.
Right? Vital signs, they are vital. And you really have to pay attention to them because the evidence shows that those are predictors.
Now, when I look at the two vital signs side by side, it looks like in the updated version of the high risk vital signs, the previous version just said it was 2 to 8, and then over eight was considered like adult vital signs. If they were greater than 100, they need to be kind of bumped up. If they're greater than 20 respiratory rate, they need to be bumped up. And now it looks like it breaks it down a lot more. You know, 3 to 5, 5 to 12, 12 to 18, and
Right.
then 18 to 20 is
Right. Because
separate.
the eight, once you're over 12, you're like pretty much an adult, right?
Yeah,
You're an adult sized person.
yeah, typically, yeah. So,
So,
so it kind of breaks down those vital signs a little bit more, giving them a little bit more wiggle room for heart rate, and a little bit higher heart rate and a little higher respiratory rate for the younger folks.
right. But, a kid with a heart rate of 108, a 2-year-old with a heart rate of 180 is not just because they're crying. Right?
Right.
Like, there's something
Right.
going on there.
Yep. Absolutely right. Like,
Right.
okay, maybe if they're screaming and yelling and you're, fighting you, but by the time they settle down for even a second, like it shouldn't be that high.
right. Absolutely. Absolutely. So, um, again, like especially your older patients who present with these really vague, general malaise kind of symptoms, and those are the people who get turfed, right? They're like, oh, they're fine, they're just old, right? And those are the people that we really need to be sharp about,
Absolutely.
right?
Now, one thing there's a mention here and there about particularly about pediatric temperatures.
Hmm.
Can we talk a little bit about that? Like
We absolutely can.
that's with the vital signs. Again, they break them down a little bit more in the new version.
Hmm.
But one of the things that it still includes is temps in kids because that's a critical factor
Yeah.
that I think sometimes people tend to forget.
Well, they don't like to take rectal temps.
Well,
It
there is
freaks
that.
them out, right?
There is that. So,
Right? People keep trying to do temporal arterial or, axillary temperatures on an infant. Like, don't do that.
I was really surprised. I worked for a major pediatric organization and the standard temp was axillary. And I was like, I don't get it. Like they didn't do at my previous pediatric emergency room, we did either the tympanic or the temporal. This place did axillary on almost everyone to start. And then if it was, high, then they would go rectal. But they would start almost always with axillary. And I was just like, to me, I was like, I can't believe we're doing this.
Why would you do that?
It's a good question.
Well, if you look again, if you look at getting a temperature as a task rather than an assessment, then the easiest way to get that number is with a temporal arterial or an axillary measurement, right? ENA had a CPG a while ago. I don't know if it's still there, but basically was like core temperature all the way. Like nothing else is reliable,
Yeah. But
right? So you got to take an oral or rectal.
I seem to remember, and I'd have to look it up. I seem to remember that was it the temporal or the tympanic that was kind of
The
ranked
tympanic is
high,
like
like
not good, but every hospital in the world like had bought all of these tympanic things because they're easy.
Yeah. Oh, clearly. I mean,
But
clearly they're,
they're
uh,
easy in registering a number. So
yes.
it's a task. It's so I can write something in there,
Yeah. Absolutely right.
right? So, like, I think that's a huge problem, and I think you always get a temperature on a kid, under 3, I think, if the complaint warrants it, right? But certainly babies, under 90 days because that's your red flag, right? All other things being equal, a kid under 90 days old with a temperature, that's an emergency, right?
100%.
So, um, and I think we also tend to kind of roll our eyes at fever phobia, right? Like parents running their kids and they have a fever. Well, okay, so what'd you do about that? Right. And that immediately sets us up to dismiss that as a symptom. Of course, all kids, it's cold flu season, whatever.
Yeah.
So, so really understanding like what are the boundaries of safety, I think in these vital signs, especially for kids and babies, is really important.
So it mentions anything over 38.5 for over 3 months old or anything lower than 36. And I think we tend to think about when we talk about fevers, we tend to think about hyperthermia, but we forget about hypothermia.
We should really think about temperature,
Yeah,
right? Like not fever, because it's not the binary of you have a fever or you're fine, right? Because if you're cold, that's worse, right? Like cold sepsis is way worse than warm sepsis.
absolutely.
It means you're
Abs-
not perfusing at all. And I think, there's some good case examples, right? And the need for vital signs on every patient, right? It's sort of like you look okay, but they should be up triaged based on their vitals.
Absolutely. And again, a bunch of great references on that as well. And then one of the last sections they have on here is frequently asked questions,
Mm,
which I like. I think
yes.
that's good. I think that's a great way to say, hey, just in case we didn't mention it, here's a
Right.
reminder.
Just in case. Yeah. I mean, because I think a lot of people are using ESI in ways that it just is not appropriate to, right? You can't use it for billing or staffing, right? Like you can say, like all of a sudden we have this huge uptick in ESI twos, right? So maybe we need more people, right? But you can't like make that your staffing grid because you never know what's going to come in, right? So you
Absolutely
can
right.
staff according to volume patterns, certainly, and a lot of people do. I think where accurate ESI becomes really important to inform things like staffing is because we under triage so much, especially because we're like, I can't bring another patient back because we're full. So I have to make them a 3, right? Like that mentality. What we're doing in that case is we're shooting ourselves in the foot because we're like, everybody's so sick. And they're like, well, 80% of our patients are ESI 3s, but they're not. Right? So accuracy and triage is really important to understand like what you have and to inform resource allocation, like in a general sense, I think. But you can't use it to step in a way. You can't bill based on ESI because that's ridiculous. It's not meant for that. Like it is meant to assign a measure of stability or instability at the moment the patient walks in the door, right? Not 2 hours down the road, unless the patient hasn't been seen by a provider, right? That's really the only time you can change an ESI.
Boy, you just led me right to the question that I was just dying to ask is,
Mhm.
and it's addressed here in the frequently asked questions. When can we or when should we assign or change an ESI?
Yeah, when the patient has not yet been seen by a provider,
But
right?
once
So
the
in other
patient's
words, if that's it, right? So if the patient by the time the patient's in a bed with a primary nurse, like it doesn't matter. And it really, practically, it shouldn't. We know it kind of does, but just for the purposes of what ESI is for. If I'm the triage nurse and I send an ESI 3 patient out to the waiting room, and 2 hours later, we take their vitals and now they're in a danger zone, I can up triage them to an ESI 2 so they can be seen, right? What I cannot do is if I've been taking care of a patient in a bed, right? And their status changes, like you note status change, but you don't change their ESI because that's only at like the moment. It's a moment, right? It's not through the entire trajectory.
Correct. And I think that it kind of, again, brings you back to that focus of focusing on the moment, not the trajectory. And I think that's something that every ER nurse needs to hear 100 times is, yeah, you really got to focus on what's right now, what's in front of you.
Yeah. What does this patient need right now? And to be open, right? Because the patient I mean, honestly, any patient who comes into an emergency department is potentially unstable, right?
100%.
That's why they're there, right? So whether it's their perception or reality that like something bad is about to happen, that's why people go to emergency departments. And so we need to kind of like be open to that. So
100%. Anything else people need to know about the ESI updates?
I think, the 5-level triage is just really it's good. It actually stratifies patients pretty well. And, if and people are like, "Are there really only 5 levels?" Right? Should we have a level 6, a level 7, right? A level 2B, right? A soft 2, a hard 3,
I've
whatever.
I've said that before. I've said a soft 2
A
versus
soft
a
2.
hard 2 many
Meet
a times
criteria
in
or you
triage.
don't, right? You meet criteria or you don't. That's why the criteria are there. And the soft 2 is like, "Yeah, I know they meet criteria, but I don't know. I just think maybe they're fake," right? Just like it doesn't matter what you think in a way, right? Like your judgment on the validity of someone's complaint is irrelevant. Just like assess them, assign
Well,
an
see,
ESI, move on.
and that I have a hard time with that. I'll be honest, I have a hard time with that because sometimes we're like, okay, this is a 2, this is a 2 or 2 than the other 2.
A 2 year or
Eh,
2. Right.
you're like, this is a, 3 point or a 2.5
Oh my god, there's
more
no
than a
such
2.
Well, here's the thing, right? Amongst a group of 2s, there's someone who's farther along the cliff, right? Who's closer
Correct.
to the edge of the cliff, but it doesn't make the other people not 2s,
It's a good point.
right? And
Sure.
this is why this is what we got away from is, would you give this patient your last bed? I was like, take that out. I don't want to see that anywhere in
So
in
that's
this
not in
handbook.
there. Would you,
Gone.
because that was always the criteria for level 2. Would you give this
Right.
person your last bet?
Right.
That's gone.
It's gone.
Well,
It's explicitly gone because it meant that people weren't being accurately triaged. It meant there could only be 1, 2.
yeah.
Right? This is not Highlander, right? Like, there can be more than 1. You don't like, they don't have to be in a cage match to see who gets the bed
Steel cage death match in the waiting
in the
room for
waiting room.
see who gets the
Exactly.
next bed. I like it. I think it's a great idea.
Yeah. Yep, yep, yep. The patient who faints first gets the bed. But yeah, I mean, really looking at the triage decision as actually an individual assessment. Like you are assessing one person, you are assigning an acuity level. You are not comparing them to the other patients in the waiting room. Which is what people tend to do in that whole, like, "Well, would you give me your last bed" mentality. Get rid of it, because that's not what triage does.
I like that exclusion as much as I joke that, but I do like that exclusion because, that I remember oftentimes as a charge nurse going up to the triage nurse and saying, okay, like,
Who would get the bed?
yeah, who would get the bed? Or they'd be like, well, I give this one my last bed. And I'm like, I
But
get it. But then
right.
that also kind of takes into fact something that we say multiple times on how not to kill your patient is you got to triage the patient, not the waiting room, not the providers.
That's right.
So
Absolutely.
and I think we say that all the time.
All the time, right? And I think the shifts, they're not, like, really blatant shifts, like, "We were doing this, now we're totally doing that," right? But there are enough clarifications in how to apply the algorithm that I think it becomes hopefully easier to use, right? People can feel a little more confident in their decision making around it. Um, and certainly, better triage, better patient outcomes. Like we know that accurate triage leads to better patient outcomes.
100%.
So, and especially all you little newbie nurses out there, sit down, get a cup of coffee, get a little hot chocolate and some cookies, read this.
Absolutely. Absolutely. So I printed this book. I printed it and sent it to my emergency department director where I work. But then I also sent it to the emergency department educator who probably already got it or was gonna get it. But I was like, hey, here you go.
Hey, here's a thing.
Here's the newest, latest, and greatest thing. Cause you want to think that because this is free to ENA members.
Yep.
As an ENA, how do ENA non-members get a hold of this? Do they?
Um, I'm not
Membership.
actually sure. I'm sure it's going to get passed around. How much does it cost if you're not a member?
There's
Learn it?
no option that I see
Hmm.
for non-members to get it
Oh, I don't know then.
because it's an ENA university. It's free in ENA university.
Mhm.
But that's where you get it. You got to be an ENA member to get there.
Oh, good question. All right. Well, I'll see if I can find out about that.
Yeah, ask that question because I'm curious.
Mhm.
Because
And do.
I mean, in my mind, like everybody needs like a copy of this, and
Oh my God. Yeah.
I remember
Absolutely.
as a director in the ER, like one of the first things I did was I went through and I ordered, yeah, from the old AQ something
AHRQ. Yep.
AHRQ. I ordered a couple ESI books to make sure that we had some at the one at the nursing station and a couple in triage, just so they had it as a reference.
Yeah,
And
but like the thing to remember is the process of value. Like a triage decision is a summative clinical judgment, right? And so, in that sense, this is a microcosm of emergency nursing, right? In like 2 minutes or 3 minutes, we're doing a focused history, medication history, a focused assessment, and we render a clinical judgment.
yep, absolutely. Cool. I think this has been a great update of the latest and greatest ESI version. And
With lots of citations.
lots of citations. As always, Dr. Wolf, this has been awesome.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.